Dear colleagues, guests and friends, according to the tradition of this university, I would like to open this academic ceremony with the following words. Spiritus Sancti Gratia, illuminet sensus et corda nostra. Please be seated. Welcome to the inaugural lecture of Professor Indira Tendolkar. She has been appointed as Professor in Psychiatry at Radboud University as of the 1st of May 2022. My name is Jan Smit. I am Dean and Vice Chairman of Radboud UMC Executive Board, and I replace Rector Han van Grieken of the Radboud University this afternoon. Thank you very much for your attendance to this meeting. A special welcome, of course, to the guests of Indira. Indira's mother, great that you are here, Brigitte Tendolkar, her husband Guyen, daughter Emma, and her partner Samuel, son Luis, and cousin Shirish and her partner Sunita, who represent the American branch of the Tendolkar family. And of course also a very warm welcome to the other friends and family. Indira Tendolkar studied medicine at the University of Aachen, where she received her cum laude doctorate in 1995. She was an associate at several international universities, including the University of Magdeburg and the University of St. Andrews in Scotland. Indira Tendolkar specialized in neurology at the University Hospital of Cologne, followed by specializations in psychiatry and psychotherapy. She obtained her habilitation thesis in 2006 on the neuropsychological correlates of memory deficits in patients with schizophrenia. Indira has been with the Radboud UMC since 2003, where she is a highly valued colleague and active in healthcare, education and research. From 2015 onwards, she became chair of the theme Plasticity and Memory at the Donders Institute of Brain and Cognition, and in 2022 she became head of the Department of Psychiatry. She's broadly active in a variety of national and international organizations. But her contribution to society is not restricted to her professional activities. In her private life, she's committed to volunteer work, among which the German Food Bank, which is, of course, in line with the title of her lecture, There May Be Better Times, But This Is Ours. Indira, the floor is yours.
Honored Rector, dear colleagues, family and friends, it is a privilege and a pleasure to share with you my thoughts on the contribution of the Department of Psychiatry to academic research, education and healthcare in the Netherlands. Before I do so, I would like to thank my guests who have come from different parts in Europe and Netherlands. We have had a very interesting meeting yesterday with the Global MRI ECT initiative, and this morning during a symposium where senior researchers of the department shared their expertise with us on the translation of scientific discoveries into psychiatric practice. I think you will agree with me that mental health represents an integral part of an individual's capacity to think, emote, interact with others. We can create our mental health by acting in the world and by actuating our own being. We are all aware how mental health and well-being are put at risk by a wide range of factors, spanning individual, social, and environmental levels. Together, we can set a stage where we aim not only for the improvement that must be made, but acknowledge the achievement we already have. When Nobel laureate psychiatrist and molecular scientist Eric Kandel postulated his core belief, all functions of the mind are functions of the brain, he made very clear that despite the more complex nosology of psychiatric disorders, they are based on biological defined changes of the brain. 25 years later, we understand the brain is only the last meters we must investigate. From a biological point of view, a dissociation between mental and somatic health is not understandable. This is also supported by the high level of psychiatric comorbidity in severe somatic diseases and vice versa. I like to propose 3 pillars on how we can have a significant impact on healthcare. I argue that these can be also applied to other somatic disciplines and that we should build upon them in an interdisciplinary way. I have called the first pillar boosting mental health in times of change. And by this, I largely mean preventing maladaptation and fostering resilience to stress. We must understand that the effects of medical care may be more limited than commonly thought and integrate a powerful role for social factors, also in our education agenda. Different levels of prevention are vital products of our academic research, trying to understand the mechanisms of health and illness, how to treat patients and their diseases more effectively, and how to provide healthcare to community more effectively. The second pillar relates to psychiatric syndromes often coming with overlapping or potentially unifying patterns, while dissociating on different behavioral symptoms has also shown great clinical advantage. We must translate our findings from biological psychiatry on underlying domains of psychiatric symptoms such that we can use them in diagnosis and care. Thirdly, advantages of an individualized approach are obvious for any medical specialism, and in theory, personalization of treatment should lead to lower health costs. Arguably, in most areas of psychiatry, predictors of treatment response or side effects are simply unavailable. However, much of modern medicine deals with diseases that are multifactorial, that have some genetic basis, and that are very likely heterogeneous, such as diabetes, hypertension, or chronic obstructive pulmonary disease. Let me explain those 3 pillars in more detail as they form the basis of our research, patient care, and education. So let us look at the first pillar on prevention. We cannot boost mental health if we do not consider the specifics of adaptation on the brain across roughly 4 different periods, from childhood to adolescence, adulthood, and aging, and the consecutive impact of gene by environment interaction during each of these periods. At the Radboud University Medical Center and across faculties at the Donners Institute for Brain Cognition and Behavior, we have consequently conducted research along a fully translational chain studying the mechanisms and consequences of normal and abnormal neurodevelopment on the one hand, and on the other hand, the neurobiological effects of environmental challenges, as well as their behavioral and emotional consequences. It is the privilege of our time that we can understand more and more complex dynamic systems and learn from repeated measurements and monitoring across different phases. It is also important to derive normative ideas on how changes in the environment alter the healthy brain before deriving assumptions on maladaptation. Let me highlight a few scientific results from our research groups to support this age-sensitive prevention approach. The earlier adverse events occur in life, the more likely they are to affect all subsequent levels of mental and physical development. Childhood adversity promotes subsequent health problems by physiological challenge of the hypothalamic pituitary adrenal axis. The potential of social influences to shape the developmental trajectories has to be considered as well. Childhood adversities are among the most consistently documented risk factors for psychiatric disorders and their comorbidity. On the left side of this slide, I propose, based on recent literature, including our own work, that childhood adversity can be deconstructed into at least 2 underlying dimensions: deprivation and threat, that are associated with distinct neurocognitive consequences throughout the lifespan. The concept of threat covers different forms of violence, ranging from community to domestic violence, and as a main threat, physical and sexual abuse. Poverty, neglect, and institutionalization may lead to high levels of deprivation. A combination of both axes result in complex exposures, while the opposite forms the environment promoting typical development. On the right side of the slide, I therefore propose risk identification, both at the level of the adversity as well as the somatic staging that are needed in the context of primary and secondary interventions. We are addressing this with our academic network of general practitioners affiliated with the primary care department of the medical faculty. This includes a good interaction of social domain and primary care with consultation of secondary mental health care where necessary. It is important to broaden the assessment of interventions beyond mental health measures and include stress-related health outcomes such as asthma, infection, inflammation, and insulin resistance. Here, the prevention and intervention work of the academic child and psychiatry institution character is of high importance. A healthy transition from youth to maturity requires the space for development of self-management skills, self-efficiency in social interactions, and skills that foster well-being. As I tried to sketch out with the help of my former PhD candidate Fleur Dauser, current challenges include recovery from social changes during the COVID-19 pandemic, digitalization of learning, social interaction and work, and effects of climate change. Risk assessments of environmental challenges have been unspecific, often retrospective, and were neglecting young adults as a specific target group. My colleagues Pierre Herpers and Wouter Stahl propose that the interdependent development of biological factors, attachment, moral reasoning, and emotion regulation in an overprotective environment lead to higher risk for social anxiety and later during development to emotion dysregulation and severe internalizing behavior disorders. A goal of the knowledge and innovation agenda for the life sciences and health sector is to reduce health disparities between the lowest and highest socioeconomic groups by 30% by 2040. Successful mental health prevention needs to be based on the needs of people with attention to socioeconomic health differences. Together with a core team under the lead of Pim Assendelft from the Department of Primary Care, we will organize the Prevention Access Living Environment Primary Care Hospital for the citizen patient and give it evidence-based content. I'm very glad that my colleague Gusje Collien has received several grants to develop a prevention program of serious mental health problems that is based on the joint expertise of mindfulness-based stress reduction on the one hand and knowledge on the neurocognitive profile of young adults on the other. In line with our further initiatives within the academic alliance with the UMC in Maastricht and the Department of Psychiatry in particular, we promote youth-driven, professionally supported initiatives like at ease, providing a low-threshold peer-to-peer counseling, anonymous and free of charge. Lifestyle awareness and mental well-being of students is an important line of educational research led by Marjolein van der Pol within the Radboud Health Academy, and together we are developing future assessments and interventions. While most research supports a general age-related decline with respect to cognition, emotional aging can give rise to protective psychological effects, creating a paradox of resilience and vulnerability, potentially related to impact of acute stress. Surprisingly little work is done on this, and I'm happy to summarize a neuroimaging study in healthy elderly males of my colleague Daphne Everaert on the left side of the slide. The bar graph depicts the brain activation of the amygdala, an important brain region involved in salience processing, which means processing the distinctive features of a stimulus, often evoking an emotional response. Compared with younger adults, healthy older adults showed increased responsivity of the amygdala during face and emotion processing while stressed in a laboratory setting. However, if you look at the amygdala activation in rest, as pointed to by the blue arrow, you can see that the elderly group expressed a less activation in a rest state, potentially showing a more resilient way to process a salient environment, as is in line with behavioral, sociological, and geriatric studies. These findings suggest that increased reactivity of this neural circuitry after acute stress induction may constitute one mechanism by which emotional well-being during healthy aging could rapidly change into heightened vulnerability for affective disorders. In the context of an aging population that is admitted into this university hospital center, we investigated otherwise mentally healthy males before an MRI-guided biopsy procedure. Stronger use of maladaptive emotion regulation techniques, elevated depression scores, and higher connectivity of brain regions mediating salence processing indicated higher stress susceptibility during the procedure. Certainly, with tertiary preventive initiatives, we can develop behavioral interventions to counteract such vulnerability in the growing population of elderly people. In line with colleagues from the Department of Medical Psychology and colleagues from the Center for Integrated Care, I would like to advocate that basic shifts in cognitive and affective capacity must be considered during medical decisions. One important improvement we have made with various initiatives over the last decade is building a framework beyond symptoms. Symptoms should remain an important starting point, but we know that constructs such as inability to experience pleasure and executive function cut across many current diagnostic categories. Research in the field of clinical neuroscience has shown us that symptom-based diagnostic systems typically reflect a convergence of multiple distinct biological mechanisms, contributing to significant clinical heterogeneity within disorders and a high level of comorbidity between them. To illustrate the typical co-occurrence, I have included a graph on the right side of the slide showing the diagnosis of patients submitted to our outpatient clinics. Mood disorders, including unipolar and bipolar depression, are most occurring, but often are combined with ADHD, anxiety, substance abuse disorders, or autism spectrum disorders. We have taken advantage of the basic concepts of the National Institute of Mental Health research domain criteria. We collected clinical, neuropsychological, genetic, and neuroimaging data from our outpatient clinic between 2016 and 2021. This cohort was initiated by the late Art Schene and presents an enormous team effort of all PIs of the Department of Psychiatry in close collaboration with colleagues from the Donner Center for Cognitive Neuroimaging and the Department of Genetics. At this point, I would particularly like to thank my colleagues Rose Collard, Philipp van Eindhoven, and Jana Freisen, who have put a tremendous effort in setting up the study and integrating it in our diagnostic pipeline. I would also like to thank all the clinicians who have contributed to this and the patients that have participated in this cohort. I will summarize a few findings during the next slide that have had impact on the decision to organize care programs in a transdiagnostic manner and start building the next generation of routine outcome monitoring. If we assume unifying and dissociating pattern across the currently diagnosed psychiatric symptoms, an important step is to look at the overlapping genetic architecture among different disorders. Our former member of the Department of Psychiatry and Genetics and now new head of the Department of Cognitive Neuroscience, Barbara Franke, has significantly contributed with her group to understanding the genetic liability for major psychiatric disorder phenotypes under both a disorder-specific and a transdiagnostic framework. An important factor that has been to quantify the combined genetic susceptibility to disorders in the form of the so-called polygenic risk scores, whose usefulness has been shown in risk prediction for common diseases, in identifying cross-disorder genetic association, but also in investigating complex genetic traits that are relevant to multiple disorders. In the aforementioned mindset cohort, Ingji Chi determined subject-specific multi-base polygenic risk score profiles and associated them with psychiatric diagnosis, comorbidity status, as well as cross-disorder dimensions. A high polygenic risk score for depression was unselectively related to the diagnosis of mood disorders, anxiety disorders, ADHD, addiction, and the comorbidities among them, supporting the overlapping genetic structure between these clinical syndromes. Then it is important to understand the association of such an underlying risk with behavior. And here I'm drawing your attention to the graph on the right side of the slide, where in particular my colleagues Joosje Quist and Peter Mulders have done a fantastic job to extract the functional components from many questionnaires we use in psychiatry and conduct a factor analysis that clearly supports domain characteristics also identified by the NIMH, namely negative valence, social processes, cognitive systems, and arousal. Critically, the genetic predisposition for depression I showed on the left side was selectively reflected in a functional domain that includes different constructs for the negative valence system, reflecting an affective dysfunction covering mood decline and fear. This finding suggests that a shared domain of negative affect and cognition could underlie its association with multiple disorders. The genetic basis of such a functional domain and its adaptation to environmental challenges should ultimately be reflected in the association with brain patterns. This brings me to this slide, where I try to summarize the link of the functional domains to brain patterns. Here, I would in particular like to highlight the work of Philip van Eindhoven, Jasper van Oort, and Peter Mulders, in close collaboration with Niels Cohen, André Macon, and Gillian Fernandez from the Department of Cognitive Neuroscience. On the left side, you see in patients with different diagnoses such as depression, anxiety, ADHD, and autism, the functional domain, negative emotion, which is shown in blue, organization and procognition in orange, social perception and functioning in gray, and arousal and inhibition in yellow. Such functional domains can only be related to several brain regions that should be connected in one way or the other. Peter Mulders has built on the pioneering work of the group of Christian Beckmann and was able to show a spatial topography whereby these functional domains are represented in the functional organization of a certain part of the basal ganglia, the striatum, across disorders. On the right side, you see large-scale brain networks of the same kind of patients, but this time looking at the relationship with acute stress sensitivity, which we induced in a laboratory setting. Our results support an increased vulnerability to stress across all patients characterized by relatively decreased connectivity of networks, mediating executive control, and an absence of decrease in the resting state connectivity across all disorders compared to healthy controls. These findings may reflect a diminished top-down control and a tendency to more pronounced self-referential processing, a disorder when being stressed. How can we make use of these transdiagnostic findings? Negative biases in the cognitive domain of attention or memory have been intensively investigated as potential markers of depression and target to be modified by Jana Freisen and her group. This is based on long-standing work of Eni Becker and Mike Rink of the Department of Clinical Psychology of the Behavioral Science Institute. Negative memory bias, which means an increased tendency to remember negative information, is thought to be one of the main cognitive risk and maintenance factors for depression. On the left side of the slide, you can see results from a study conducted by Fleur Dauser on the expression of negative memory bias across patient groups with stress-related and neurodevelopmental disorders. All patient groups showed stronger negative memory bias than control subjects. This was individually associated with symptom severity indices and can thus be seen as a characteristic of depressotypic processing style and present in different mental disorders. This brings us to the bar on the graph on the right side, where we examined negative attention bias in ADHD as a neurocognitive marker for comorbid depression. The bar graph depicts gaze reactions to photos with different facial expressions. ADHD patients show a relatively positive attention bias towards happy faces, as shown by the arrow, while negative attention bias in ADHD likely indicates subclinical comorbid depression. In translating research to innovation in diagnostics, we are implementing bias measurements in our electronic health data. Ongoing efforts in different medical fields aim to achieve clinical staging models in order to define disease progression, predict prognosis, and allow tailored treatment. We are ideally positioned in the interfaculty efforts of the Donnes Institute to provide a scientific framework for personalization of mental health care. We are moving towards a stratification approach that can help a great deal in providing mental health care. Computational psychiatry promises to advance preventive precision psychiatry in a way that is superior to classification based on traditional behavioral and neural data alone, by combining multiple levels and types of computation with multiple types of data. Here we can rely on a strong network of excellent researchers at the Donnes Institute, such as André Marcan, in particular the work of my colleague Roshan Kouls, who is trying to bring together the efforts of biomarker and theory-driven research across the entire campus. Over the upcoming years, we will therefore continue our biomarker research for prediction grounded in recent advances in machine learning, multivariate psychometric modeling, and high-dimensional big data. We will combine this with more theory-driven research for explanation. The way we can adapt and exploit our electronic healthcare records may need some patience, but recent healthcare record-based phenome-wide association studies that analyze many phenotypes compared to a single genetic variant or other attribute support that this is the way to go. We are very clearly moving beyond the standard AI-based applications in medical imaging to a dynamic visualization of biosocial factors of vulnerability and resilience that will guide us in our care for patients. Currently, we can already individualize treatment, particularly in the field of non-invasive neuromodulation and pharmacotherapy, as I will show in the next slides. Non-invasive neuromodulation, where we induce electrical activity in the brain at different levels of intensity in a series of treatment sessions, is gaining new attention. Despite its safety and superior efficacy, use of electroconvulsive therapy for depressed patients, where we induce a very short seizure under anesthesia, is surprisingly low in the Netherlands, potentially due to limited knowledge on the optimal position in treatment algorithm, lack of knowledge on cost effectiveness, fear for side effects, and the outdated representation of ECT. To fill this gap, almost all ECT centers in the Netherlands are joining efforts and compare it to treatment with antidepressants in merged clinical and research cohorts. Under the neat project management of Annemieke Dolz from Utrecht and Philip van Eindhoven here at the Radboudumc, we will increase knowledge on cost effectiveness and safety of ECT. And with the kind support of the Board of Directors of the Radboudumc and in close collaboration with the brain stimulation groups at the National Institute for Mental Health and the Center for Addiction and Mental Health in Toronto, we will develop more insights in the possibility to add magnetic seizure therapy to non-invasive brain stimulation options in the Netherlands, as this method relies on powerful aspects only ECT has at this point, but may come with less cognitive side effects. Repetitive transcranial magnetic stimulation is increasingly being used, in particular in the treatment of severe depression, but will have a broader application. The therapeutic effect of RTMS is achieved by delivering magnetic pulses through a coil that is positioned above the head. The magnetic field causes an electrical current in the underlying cortex that modulates neural activity. In the Netherlands, we have a long tradition to study the potential use of RTMS with excellent research groups in Amsterdam, Groningen, Nijmegen, Maastricht, and Utrecht, tackling the mechanistic underpinnings and the clinical application. While therapeutic interventions are often studied and developed as monotherapies, in practice they are typically used in combination. The potential to leverage combination therapy in a way that yields synergistic rather than additive effects is a focus of several RTMS studies we are conducting. Psychotherapy is the most individualized form of treatment, directly taking the personal experience of a patient into account. Its efficacy may be improved by considering the state of the brain as the patient undergoes psychotherapy. I am very glad that we can participate in a large trial led by Odile van den Heuvel from Amsterdam on the combined use of RTMS and extensive exposure therapy in severe forms of obsessive-compulsive disorder. Together with the academic workspace of addiction at the Radboud University and Pro Persona as the largest mental health care provider in our region, we are working on the innovative use of RTMS in clinical care. It is necessary to understand how we can induce the best brain state to induce a learning experience that is consolidated over and over again, ultimately leading to changes in behavior. Therefore, we are part of an interfaculty neurostimulation network coordinated by Lendert Verhagen at the Donde Center for Cognition. We are moving forward in an individualizing localization site in order to get the most optimal brain state. E.g., localization and use has helped us a great deal to have an idea of change in neural activity in relation to non-invasive neuromodulation. Neuronavigation enables us to position the TMS call to target specific anatomical sites based on an individual subject's structural brain images. Over time, psychiatric disorders began to be conceptualized as disorders of brain networks, and since then we have begun to look at functional hubs that need to be modified to change the network interaction. In parallel, it has become clear that the effects of RTMS are not restricted to the stimulated region, but propagate to affect the network of regions connected to the stimulation site. This provides us with a range of new opportunities to derive functional connectivity-based personalization, and we will test its efficacy over the upcoming years. A final step we are trying to apply in the context of delirium treatment, in collaboration with Arjen Sloter from Utrecht and Willem de Haan from Amsterdam, is the use of computational models allowing us to infer how the modifications of neural properties may influence emergent neural activity and response to treatments. Non-invasive brain stimulation can be applied in numerous ways, which differ regarding the location of electrodes, intensity, and type of stimulus. The optimal individualized approach to restore network integrity can be assessed with a computational model that simulates the unique network alterations of a particular patient. Optimization strategies for stimulation can then be quantitatively investigated, which can thereafter be applied in the same patient. We are moving towards a personalized drug selection on the basis of predictive baseline analysis containing quantitative aspects of functional domains and neurocognitive and somatic changes. In the context of our highly specialized care, we have to take into account gender-sensitive medicine, lifespan, physiological and clinical conditions that can lead to pharmacokinetic peculiarities. A second important pillar of personalizing pharmacotherapy is therapeutic drug monitoring. Here at the Department of Psychiatry, we focus on potential effectiveness and cost utility of screening patients with pharmacogenetic testing. We have shown that tricyclic antidepressant dosing based on pharmacogenetic information significantly reduces the time to reach a therapeutic drug level and is accompanied by an earlier reduction of adverse effects. This work is led by Joost Lernsing in collaboration with Marieke Koenen, now Erasmus MC, and Rob Arnoudse. Part of our addiction psychiatry treatment is based on gradually weaning the patients off opioid medication or other substances in order to minimize and reduce withdrawal syndromes. Arnd Schellekens, together with a dedicated team of nurses trained in motivational interviewing and a physician assistant monitoring the somatic side effects, provide an innovative reduction program with Suboxones for many patients with opioid addiction, often occurring in the context of chronic pain. Another important part of personalized tapering is that longer duration of use, higher dose, and specific antidepressants affect the risk of antidepressant withdrawal effects. Anne Speckens and her team, in collaboration with primary care colleagues Tim Alde-Hartmann and Peter Lucassen, have provided mindfulness-based interventions during antidepressant withdrawal and identified important facilitators and barriers of discontinuation of such as pre-existing beliefs about depression, medication and tapering, current experience with antidepressant medication, life circumstances and clinical support. My colleague Eric Roe has dedicated some of his work on difficult-to-treat depression to investigate usual and slower tapering strategies for two antidepressants that are notoriously difficult to stop, looking at effectiveness, quality of life, and cost effectiveness. I'm very glad this is another example of the excellent collaboration with the psychiatry departments at Amsterdam Medical Center, and in this case, Christian Finkers. Any individualized pharmacotherapy cannot stand on its own and urgently needs to be combined with psychotherapy, particularly in the complex comorbidity as we encounter them in our patients at the department. Our psychotherapy experts such as Tom van den Heuvel try to innovate concepts of stigma and dialectic behavioral therapy so that they benefit the need of patient groups with impulse and stress regulation disorders. I think throughout my lecture today I've made clear that for complex chronic disorders like psychiatric disorders, just in line with other disorders such as diabetes or asthma, we need convergent solutions to move forward towards personalization of mental health care. Psychotherapy, medication, e-health and brain stimulation, social support, education and team care are all part of the package needed for improving outcomes. In mental health care, we believe that in accepting multiple solutions to a patient's problems, we may ultimately be more personalized in our care. However, the complexity of problems demands also a stringent alignment across different levels of care and social support we have not yet realized. Packages need to be built around patient choice. Of course, this is not new to any of you, but we consequently have to pursue this and leave no room for ambiguity that may be disadvantageous for our patients. We need to take into account that we have different timings of different forms of treatment. It is important that we keep offering longer-lasting psychotherapy interventions, while other specialized forms of care and more biological forms of treatment may be shorter-lasting or may occur in a recurrent way, demanding a combined support from different domains. Personalization of mental health care is not only achieved by convergent thinking, yet we need to embrace structure and clear solutions. With the reorganization of our patient care in centers and defining patient-centered care paths across the borders of departments, we are really having the chance to realize this now. I hope I could convince you that in fact we do have several promising approaches in psychiatry as a medical field, but all of these rely on different kinds of networks. And this is in fact also why our experts in education, Marleen van Beek and Desiree Oosterbaan, develop courses related to interdisciplinary transcending competences such as communication, self-reflection and professionalism in our bachelor and master education, and promote the setup of interdisciplinary training. Certainly, the implementation of a certain assertive community treatment has helped a great deal, providing the majority of treatment, rehabilitation and support services that individuals need to achieve their goals and live independently. I'm very happy here in Nijmegen, the regional agreement interaction is good with the involved psychiatric institutions and the acute care program of Pro Persona in the lead. A recovery-oriented approach demands a more dynamic interaction between the social and the medical branch, where clients should not stay too long within the mental health care on the one hand, but professionals within the social domain also need to have the opportunity to easily attune with primary and specialized care for both prevention of relapse and in acute and chronic needs. My colleague Aura Thiemen, who has been appointed as head of the Department of Primary Care, will give her inaugural lecture tomorrow and reflect on the role of primary care in this and other networks. A strong primary care department within a medical faculty helps us to install a living lab on how to innovate care in a transmural fashion. With our top GGZ partners in depression and anxiety, we are joining forces to help primary and secondary institutions to implement care standards and decision aids both for professionals and patients. I would like to thank the enormous effort of Jan Spijker and Gert-Jan Hendricks for developing excellent expertise centers within Pro Persona Healthcare Institution and in a joint network also with the faculties of social and medical sciences. We also benefit from the strong general hospital psychiatry in the region, and here I would like to mention the interaction with the Rijnswaard Hospital in Arnhem on different topics ranging from difficult to treat depression to challenging behavior of patients on somatic wards. Joint residency trainings with the Canisius Wilhelmina Hospital has created a young generation of psychiatrists that truly aim at working together on perinatal and postpartum psychiatry and non-invasive neuromodulation. International alliances we form provide the biggest opportunities to account for diversity we need in learning healthcare systems. Yet, much of the studies in relation to the treatment of severe psychiatric diseases have only been conducted in rich Western countries. We do see a trend of integrating approaches in the field of psychiatry from South American, African, and Asian countries. However, I often get the impression that this is mainly occurring in the context of reverse innovations, providing cheaper solutions also for us here in the Netherlands for the rise of health expenditures due to cost escalation. I think we should not narrow the definition of health innovation by the national income. The latest classification of the World Bank positions 137 countries in the low and middle income categories, representing 63% of countries in the world. The use of such a broad classification in global health scholarship requires considerations, both in terms of its utility and its implications in perpetuating divisions and separations between countries that are not warranted and fostering otherness. We need to critically examine how asymmetries are maintained in the domain of global mental health. To take the example of currently often discussed well-being of the early career investigator, my work for the Wellcome Trust and India Alliance has helped me a lot to learn also about the needs of young professionals in not-so-rich Asian countries. I can tell you the topics are the same. Academic exchange provides a unique opportunity to learn from each other's environmental challenges. Together with the Hogeschool Arnhem-Nijmegen and several mental health institutions such as Pro Persona and GGZ Oost-Brabant, we are building up a mental health alliance that fosters the exchange between mental health professionals from various backgrounds and countries to learn from each other's approaches. This work is supported by the volunteer group of the World Psychiatric Association and a set of senior experts that dedicate their free time in training and teaching. Here I would like to thank particularly our two such senior experts, Jacques van Hoof and Cor Senef, as well as my colleague Susanne Young, to support this network with the foundation they put together. In this context, I would like to greet via the streaming my colleagues in Cambodia and from the Diponegoro University in Semarang, Indonesia, with whom we will create joint psychotherapy and neurostimulation trainings. I would not stand here today if it wasn't for all the different teams that have promoted me throughout my entire life. On such a public moment, one can only get into problems because I cannot name all the names I have engaged with over the last almost 30 years of my career. As many, I have had the heroes of my youth and academic teachers that have helped me finding my way. For now, I start by expressing my gratitude to the Board of Directors of the Radboud University Medical Center and the Board of the University for nominating me for my prior chair in clinical neuroscience and later the nomination for professor in psychiatry. I especially like to thank our Dean Jan Smit, who has supported me a lot as I very suddenly had to embark on a new function, which was not really the kind of talent track we have in mind. We all know that without trust, there's less innovation, collaboration, creative thinking, and productivity, and people spend their time protecting themselves and their interests. Therefore, I also want to thank my former head of department, Jan Boutela, who had the trust to hire me, and psychiatrist Maurits Nijs, who helped me to integrate myself into patient care, and who was an inspiring director of the National Education Program in Psychiatry when I became the director of the National Residency Council in Psychiatry. I also like to thank Paul Hodiamont and Martin Bijker for their support during their lead of the department. I also want to take a moment to thank and remember the late Arts Rehne, who led the department between 2014 and 2021. For many of us, his driven way of working in different academic quotas was and still is an inspiration, and he has set the stage for network care and research in the field of stress regulation. For me, he was an inspiring mentor in many aspects of life, and I still miss him a lot. It is an honor, but also a great challenge to follow him in his footsteps. Standing here today would also not have been possible without all my colleagues with different professional backgrounds at the Department of Psychiatry. This starts with our concierge Paul, who is looking so well after many different things. Many thanks to the secretaries in the front and back office, in the education team, and in our management team, who try to support our different academic tasks, each of which comes with demanding agenda on its own. A big thank you for the teamwork with many nurses, social workers, and occupational therapists over the years and their critical reflection on what our patients really need. I think it is a good sign that I have several staff psychiatrists and psychologists I work with for so many years, like Monica Popp, Joost Jansing, or Kathalijne Robbins, while at the same time a new generation like Elke Schroneveld, Guusje Collien, Lotte Witte, and Janneke Zingstok keep coming in that help the cultural transition of baby boomers like me. I'm sharing with you a recent photo of approximately 60 of our 320 members of the department with whom I'm very much looking forward for our future endeavors. I would like to thank Hendrik Ermers and Malus Peters as managing and nursing directors, both of our Center for Brain and Senses and the department, for being so wonderful partners in crime. Our academic psychiatry department flourishes also because of being well integrated within an interfaculty Donders Institute for Brain Cognition and Behavior. Next to the team spirit of all researchers, credit has to be given to Guillen Fernandez, who has served for many years as the director of the Donders Center for Medical Neuroscience and continuously tried to integrate the medical faculty within the whole Donders Institute and vice versa, which has led to excellent interdisciplinary research at the interface of genetic, molecular, and cellular processes at the one hand of the spectrum and behavioral, cognitive, and computational analysis on the other hand. I hope that also in the future we really keep going beyond the aims of one or the other faculty towards a bigger aim of the entire university, as has been formulated with the Healthy Brain Initiative and has been realized by the Healthy Brain cohort created by many colleagues from different faculties and the Max Planck Institute. Within the Donders Center for Medical Neurosciences, it has been a great pleasure to work closely with Erno Hermans and Benno Roosendaal over the last 3 years in trying to coordinate the basic system-level and clinical neuroscience initiatives of our stress-related disorders team. I'm very glad that Erno is the spokesperson of our future research program, Stress and Mental Health. I'm only showing photos of the colleagues I have worked with the most over the last 19 years in a team-based working environment. But of course, there are many more, and this has led to a wonderful collaborative network. Together, we can accommodate both exceptional individuals pursuing great discoveries, as well as groups of collaborating scientists testing scientific questions in a systematic and sustainable manner. In a broader sense, this brings me to the migration privilege I have. I'm coming from a family that has promoted an international education, starting with my grandfather doing his PhD in Königsberg, today's Kaliningrad, about 100 years ago. Both my own as well as my husband Guillen's father received a very good academic education in their own country and were eagerly embarking on new possibilities abroad. While certainly back then such a migration came with more obstacles than nowadays, social mobility has always been a positive core value of my Indian-German family that is partly present here today, thereby engaging with people from different backgrounds, including countries of origin. I must say that openness to less straightforward use in language is an important factor that I did not realize myself until I started working in Dutch, where I remain a foreigner with a limited source of expression. Then it is important to encounter what I do, namely all the time, that people around me really try to understand what I mean. I had a very modern father that took his responsibility in the family and in equal career opportunities for my mother. Thus, I was looking for a mate that had made similar schemas, and no wonder I selected Guillen, who has a father of Spanish origin and whose mother had a career on her own, as had mine. Together, we have embarked on a long journey with stops in different cities of Germany and abroad. We have very much enjoyed our early years in research and specialization in neurology together and carefully secured our family needs while pursuing equally a career that sometimes had different timings as we decided to opt for children of our own. Most importantly, after almost 30 years, Guillen, I still enjoy traveling in many ways. While I think some of the audience might think that our interests are related to cognitive neuroscience and work, I can reassure you that it is actually more about art, cooking, and politics. I will not embarrass our children, Emma and Louise, more than to say that they are my beloved reality check and that I truly hope they will succeed in finding their individual ways as well. For those who know me will probably say that I do not like to socialize too much, but maintain several long-lasting friendships. I'm very glad that people I know for 30 years or longer are also here with me today, and others are watching it on the stream. The relationships are so essential to our well-being. I would not be here today if it wasn't for and because of several women of my family, in particular my mother, whom I would like to thank for having empowered me to become an independent person and care for the social well-being of others. I have chosen to exemplify the many other female role models in my family by showing a photo of my Indian grandmother, who was trained as being a surgeon in the beginning of the 1930s in Mumbai, before she unfortunately died too early of breast cancer. Also, my mother-in-law has been very inspiring for me, being one of the first female judges leading a chamber at regional court in Bonn, with a special focus on medical malpractice. None of those women had a very straightforward career because of many obstacles they had to overcome, but all fought for their professional and personal independence. They accepted both challenges as well as burdens as they belong to life. I hope not only that with the title, but also with the content of my lecture today, I can convince you that we need action and reflection. We are being shaped by our environment, but we also shape our environment. We have to take our privileged position to make change happen. Thus, I hope you can forgive me if I come to an end with a rather broad call formulated by the gorgeous Amanda Gorman. When day comes, we step out of the shade of flame and unafraid. The new dawn blooms as we free it, for there is always light, if only we are brave enough to see it, if only we are brave enough to be it. Ik heb gezegd.
Professor Tendolkar, thank you very much for your impressive lecture. I know that there is much debate among psychiatrists about the efficacy of psychotherapy in terms of well-being of clients. But if you consider your inaugural lecture as psychotherapy, and I consider the well-being of your audience, I think your psychotherapy was very successful. And not only for the audience, because I think your lecture really is a prototype for an academic lecture and also represents the significance of academia in our current society, not only dissecting reality in these terms, the brain, into molecules and their connections, but also the connection in teams, as you beautifully illustrated in your department and your colleagues inside and outside the Netherlands, but also connection with society, where you really are open to the needs of our society and the patients that trust you as an academic doctor. And in that message and endeavor, you combine the knowledge and the excellence from your scientific work with the needs to find solutions and interventions. And for these interventions, we all can experience your enthusiasm. I personally have been offered to shut down my brain by your magnetic devices. I still have this offer in doubt, but I'm sure that there are many world leaders that would benefit greatly from your offer. Having said that, I think about connectivity, this is really the meaning of a university, and I'm very proud that you had this lecture today, especially with the words in which you ended, being light. Probably this is not a term that we use every day, but in the end I think this is the meaning that we can have as academicians. And therefore I welcome you in the midst of our academic society. I congratulate you, your department, the Radboudumc and the university, and all the guests that are here present. Coming to the end of this academic ceremony, I would like to request you to stand so that I can conclude with the following words. Gratias tibi agimus, omnipotens Deus, pro omnibus beneficiis tuis, qui vivis et regnas per omnia saecula saeculorum.